Okay, so before Lori starts her presentation, we're just going to go over a few housekeeping things. Today, our webinar will be about safety and avoiding Sentinel events on a journey towards baby-friendly. Dr. Lori Feldman-Winter is our presenter, and my name is Paige Bellavo. I'll be your facilitator during this call. So we have a few upcoming 4-hour clinical skills trainings. There will be one at Merit Health Natchez on Tuesday, October 23rd, and another at UMC Grenada on Friday, November 2nd. There will be a morning and an afternoon session. Trainings are open to all CHAMPS hospitals and CHAMPS community partners. And if you're interested in attending these trainings, you can go to our website, cheerequity.org, and register there. In the next few months, we will have more Wednesday webinars. For October, we will be presenting on advancing equity and breastfeeding in our communities, which will be presented by Andrea Serrano from Rose. November 7th will be safe formula preparation, when to talk about it, and who needs it. And that will be presented by CHAMPS Hospitals and Laura Burnham. December will be Baby Friendly, discusses updates to the 10 steps, and that will be presented by representatives from Baby Friendly USA. You can also find more information about these webinars on our website, cheerequity.org, as well as slides and recordings of all past webinars. I'll pass it over to Lori at this point, and she can get started with her presentation.
Thanks so much, Paige. I'm just going to share my screen. And so for anyone who is new to WebEx, it is really important for this presentation to be able to see the screen, to see the visuals. That's such an essential part of this webinar. So you may need to run a temporary application on your computer if you've never uploaded WebEx before, and as in my case, I'm in an organization where I don't have privileges to load on new software to the computer, so WebEx allows you to run a temporary application. So that's just a little bit more housekeeping. So welcome everyone to the Wednesday webinar, and I'm really delighted to be here to present this webinar, which is an abbreviated version and a first preview of the on-site Train the Trainer safety training that we plan to do with a kickoff this October in Jackson, Mississippi. The focus of today's webinar will be on steps 4 and 7 for safety issues that are related to skin-to-skin contact and the prevention of unsafe sleep and falls during rooming in. And I would be remiss if I went on without giving a shout out to my friend and colleague, Kathy Crothers, who is today at the Cliffs of Moher in Ireland, and I'm very jealous. And she was instrumental in helping to translate what we have delivered in a very conventional fashion on safety training into this much more interactive and visual, what will be a 2-hour Train the Trainer safety training, as I said, that will be conducted in Mississippi. So shout out to Kathy for all her creativity and expertise, as well as her colleague Robert, who actually did the behind-the-scenes computer work on this. So this is really the first run of this webinar, and every once in a while I may get hung up with the transition, so bear with me as we move through the content. So let's get started. The Baby Friendly Hospital Initiative is a safe set of practices that enables mothers to breastfeed with support from environmental and structural practices that provide the most optimal setting. There are risks of not being a baby-friendly hospital, given all we know about the benefits of the 10 steps to successful breastfeeding and the establishment of breastfeeding itself. The 10 steps also delineate optimal care for non-breastfeeding mothers with regard to steps 4, 5, 7, and 8. So what we're going to talk about today are a little bit of information around the why we recommend steps 4 and 7, and then also provide guidance consistent with the American Academy of Pediatrics, ACOG, and AWHONN about safety strategies The implementation of these strategies don't preclude the adoption of the 10 steps to successful breastfeeding, as well as achieving baby-friendly designation. And so, as I mentioned, we're going to focus on suffocation and falls. So to begin, we're going to talk about skin-to-skin contact and why it matters. So this is the reason why not being baby-friendly is also a safety concern, why it's so important to put safety, skin-to-skin contact and care in place. So step 4 of the Baby-Friendly Hospital Initiative is intended to support mom to initiate breastfeeding within the first hour of delivery, but now it's restated to involve putting all healthy infants immediately skin-to-skin at least until the first breastfeed or for at least the first hour if not breastfeeding. As I mentioned, this applies not only to vaginal and surgical cesarean births, but it also applies to both breastfeeding and formula feeding mothers. Skin-to-skin contact should be uninterrupted for at least the first breastfeed or for at least 1 hour, if not breastfeeding. So why? Well, because skin-to-skin care stabilizes the newborn baby's body temperature and can help prevent hypothermia. It also stabilizes glucose levels, which is important particularly in babies that are at risk for hypoglycemia. It provides cardiorespiratory stability, and that's especially important in the late preterm newborn. Being skin-to-skin also decreases pain in the newborn, so after breastfeeding has occurred in that first hour, any procedure that would need to happen, such as administration of a vitamin K shot, that would cause pain is much better tolerated if the baby is maintained in a skin-to-skin position. In addition, skin-to-skin leads to more restful sleep patterns, less crying, and better growth. This is really the environment for which all care should be provided. Skin-to-skin is also good for the mother. It decreases maternal stress, and it also improves paternal perception of stress in the mother as she relates to her baby. Skin-to-skin care results in depression scores and salivary cortisol levels that are lower over the first month among postpartum mothers providing skin-to-skin care with their newborns. And really important for breastfeeding and baby-friendly, we know that skin-to-skin care enhances the opportunity for the first breastfeed, which in turn leads to more readiness to breastfeed, organized suckling patterns in the newborn as well as the mother, and more success in exclusive and overall breastfeeding. So given that it's all associated with positives, what are the concerns? Well, the good news is that among vaginal deliveries, 85% will result in spontaneous respirations without any intervention. So for the most part, skin-to-skin care can occur immediately and without any problems and concerns that would require any intervention. 10% of babies need a little intervention, just some drying and stimulation to encourage that first breathing. 3% are going to actually require some positive pressure ventilation, so that might interfere with the immediacy of skin-to-skin, not that it can't happen afterwards. 2% are actually going to need intubation, and fortunately only 0.1% of babies are going to require a full-out resuscitation. The real concern that's been highlighted in the literature recently is SUPC. SUPC stands for sudden unexpected postnatal collapse. And there's still a real question and even a lot of doubt as to whether or not SUPC is even associated, or certainly doubt that it's in some way caused by skin-to-skin care. we do know that often SUPC occurs coincidentally to skin-to-skin care, and so many reports are linking the two and implicating that maybe skin-to-skin care has something to do with SUPC. And what we've recognized is that skin-to-skin care provides an environment that in some cases can lead to the baby's airway being obstructed, and it's probably the airway obstruction that in fact leads to SUPC. Other situations can also arise during skin-to-skin contact, such as infant falls or hypothermia, which leads to hypoglycemia, depending on the ambient environment and what's surrounding the baby and whether the baby truly is in skin-to-skin contact with the mother, or whether the baby's just on the mother's chest but still wrapped. In addition, skin-to-skin contact and SUPC reports, those that are reported about this event occurring coincidentally, often are described in the past tense. And so the baby was found, or the baby was apparently in a position that resulted in. And because of the fact that they're described in the past tense, the presumption is that these events aren't observed. And that really brings up a whole set of questions as to how much can we actually avert or offset a situation where a baby's airway would be obstructed. And so a lot of the guidance around the prevention of SUPC really is about supporting the baby to have an open, unobstructed airway while the baby's in skin-to-skin contact. So what about the immediacy? I alluded to the fact that there may be certain situations where immediate skin-to-skin contact is not advisable. However, there are many unnecessary exceptions to skin-to-skin care when, in fact, assessments can and should be done while the baby is in skin-to-skin with the mother. And there's no evidence that these assessments done on the mother as the environment for care are any riskier than assessments done on the other side of the room on a warmer bed. And providing those assessments on the mother really adds to all of the previously described benefits. In some situations, however, skin-to-skin care should proceed with caution, as illustrated in yellow, as I'll show you in a bit, or really should be postponed until maybe the baby's resuscitated, or in some cases postponed and avoided altogether. So for example, an infant of a mother that is diabetic or maybe had gestational diabetes. Well, this is green, meaning that skin-to-skin care can occur immediately. In fact, it's better for the baby to be skin-to-skin because that baby is going to be at risk for hypoglycemia, and just being in skin-to-skin contact will help to avoid hypoglycemia. What about meconium staining? I'm going to bring up a case a little bit later that will describe a baby that's born after releasing meconium. And this is a situation that requires caution, and so we'll go through a decision tree that allows you to decide whether the baby can go immediately skin-to-skin or requires some additional resuscitation. Another situation that might be cautionary is a baby with congenital anomalies. So it's important to identify which of those anomalies exist and whether any of them would result in the need for resuscitation or airway support. Other situations, such as maternal influenza, if we know that the mom, and we're coming into flu season now, hopefully everyone's going out and getting their flu vaccine, but during flu season, if a mom comes in with influenza and delivers a baby, that's a situation that the CDC has advised that the mother and baby be separated. So we would not have that baby be in skin-to-skin contact. And I'm not going to go through all of these scenarios, but you can see how highlighting any one of these boxes actually helps to inform and instruct the audience on situations where skin-to-skin would either be immediate, cautionary, where a decision tree would have to be involved or would not be advised. If skin-to-skin is not advised or, again, needs to be postponed for whatever reason, I think it's really important that everyone recognize the benefits of the baby going skin-to-skin with another support person, like a father or another family member, because it's helpful for the baby. The baby still receives all of those benefits of being in skin-to-skin contact. And in addition, the father or other support person also gains benefits by having their baby skin-to-skin. So what about the proper or optimal position of the baby while they're in skin-to-skin contact? And hopefully this will load. Took a little bit the first time. So, this image is going to hopefully illustrate the ideal position of a newborn during skin-to-skin contact, and we're going to just highlight a couple of things about that. Sorry. There we go. Hopefully you can see that. All righty. So, first thing that's important in the baby's position is that you can see the baby's face. If you can see the baby's face, then you can be sure that the baby's airway is open. And the head should be in the sniffing position, which is described in BLS. And the sniffing position allows for an open nasal airway. Remember that babies are obligate nose breathers, so they can't really breathe out of their mouth. And so it's important that the nares are seen and that they're patent and the baby's able to breathe. In addition, it's important that the baby's head is turned to one side so the baby's not facing face-to-face the ventral surface of the mother, in which case the baby's nose might be obstructed and the baby wouldn't be able to breathe. So the head is turned to one side. The neck should be straight and not bent. Again, any flexion or extension of the baby's neck could possibly impinge that baby's airway, and again, could be one of the conditions that would lead to SUPC. And finally, the shoulders should be face-to-face, ventral to ventral with the mother's chest. So the baby should be chest to chest, ventral to ventral to the mother. What's not shown here, but in addition to the position above the shoulder, you want to see that the baby's legs are flexed and that the baby's back is covered with dry, pre-warmed blankets. And finally, that mother-infant dyad should be monitored continuously by staff, and we'll go over that in a little bit. So monitoring may include vital signs as well as APGAR scores. So APGAR scores really should be assigned while the baby's in skin-to-skin contact. Monitoring is always continuous by someone who's trained in NRP, just in case the baby should have one of these events and require any resuscitation. And typically the most risky period for SUPC is about the first 2 hours after birth. And so this is the period of time that we would recommend continuous monitoring. In terms of vital signs after the first APGAR scores that are assigned at 1 and 5 minutes, vital signs should be obtained at 10 minutes, 30 minutes, 60 minutes, 90 minutes, and 120 minutes. So that's the time frame during that first 2 hours that you would want to be obtaining the basic vital signs, that baby. You want to notice that the baby's color is pink, although we all know after being in the delivery room and seeing babies after delivery that this can take up to 10 minutes after birth for that circulatory transition to occur. So be patient. Baby is normally initially blue and then ultimately will pink up over time. The baby's respiratory rate should be 30 to 60 breaths per minute, and the normal body temperature of the baby should be between 36.5 and 37.5 degrees Celsius. In terms of oxygen saturation, there's really no need for continuous pulse oximetry, although that's been suggested by many. If pulse oximetry is done, the normal oxygen saturation should be greater than 90%, which is less than what you would normally see in a baby that, maybe is 6 to 12 hours of age. So we recognize that babies in the first couple of hours have an oxygen saturation that's a little lower. If the oxygen saturation is below 90%, then we would worry about critical congenital heart disease, and that baby would need to be further assessed. And then finally, I just want to reiterate the importance of continuous staff monitoring. So one nurse for one baby. The question is how many nursing staff members need to be in the room, and depending on your staffing and the availability of immediate response by other staff members that might be nearby, you could have one NRP staff member in the room that's also observing the mother. It's unlikely that both the baby and the mother are going to crash at the same time. Not that it's impossible, but generally speaking, if one cross-trained staff member is always present, that would be sufficient, as long as that staff member is able to respond to any untoward change in status of that baby. Another consideration for skin-to-skin care has to do with the timing of cord clamping. So many people refer to this as delayed cord clamping. I like to have this, there we go. Okay, hopefully this will load on your computers. So I like to term this properly timed cord clamping, because I just think that this is really the physiologic way that baby's circulation is, and we should recognize that. After a baby is born, the lungs are still closed, and there's high pulmonary vascular resistance, meaning that the lungs are not getting blood flow. If the cord is clamped before the baby takes that first breath, then the brain doesn't get oxygen or blood flow. And it's important, therefore, to keep the cord intact to continue to provide blood and oxygen to the brain. Once the baby breathes, the pulmonary vascular resistance drops, and blood flows to the lungs to get oxygen, and blood flow then changes direction in order to provide additional blood supply to the brain, and then, and only after then, is it safe to clamp the cord. So I'm just going to illustrate this by the fact that the baby first needs to breathe, which then permits blood flow, oxygenated blood flow, and then after that, the cord can be clamped. And generally, this takes about 60 to 90 seconds. And as I said, it's appropriately timed, and it's part of the sequence of events that we're going to talk about after delivery that supports safe skin-to-skin care. And the reason I bring up delayed cord clamping or appropriately timed cord clamping is that this may be one of the factors that leads to apneic events that then is associated with these episodes called SUPC. So while the baby is in skin-to-skin contact, again, you're going to do the APGAR scores, which include color, tone, heart rate, and breathing. And you'll use visual inspection. You'll use some palpation of the lower extremities and upper extremities to decipher tone. Use your stethoscopes to determine heart rate and breathing. Procedures that are normal and non-invasive can be done while the baby's skin-to-skin. So as I said, assignment of APGAR scores, vital signs, even footprinting and security banding, all of those things don't really interfere with the baby's ability to feed, and none of them actually cause harm or pain in the baby. But there are a number of procedures that could actually interfere with the first breastfeed that should be delayed. So the administration of vitamin K can be done within 4 hours, so it can be delayed until after that first feed. The provision of eye ointment is important to prevent against any infections that would affect vision. However, again, this should be delayed until after the first feed. If there's eye ointment, the baby has a hard time being able to locate the mom's breast and areola and actually establish that first feed. Glucose monitoring typically doesn't have to begin in an asymptomatic at-risk baby until after the first feed, again, usually after about 60 to 90 minutes after delivery. And other blood work or medications that are not urgent can also be postponed. And finally, what's often done, which is the anthropometric measurements, including baby weight, should be postponed until after the whole entire first part of skin-to-skin contact. So that first 2 hours of skin-to-skin contact should really be uninterrupted, and it's really unnecessary to do anthropometric measurements during that period of time. So now let's talk about the sequence of events after vaginal delivery. And it's important to get the sequence correct, again, to appropriately time cord clamping and assessment and the assignment of APGAR scores. So number one, the baby is delivered. And the second thing that happens is really that baby's assessed. And this actually shows cord clamping, which we really want to postpone. So we're going to assess the baby, drying the baby, providing pre-warmed dry towels, replacing those towels, and ultimately taking that towel away from that ability for that baby to be directly skin-to-skin in contact. Then with the cord intact and the option to milk the cord if the baby requires any resuscitation, the baby is continually monitored during that first minute and assigned the first APGAR scores. Again, the baby should be continued to be dried. Again, replacing those wet blankets. Baby again is ventral to ventral in direct skin contact with the mother, and leaving the hands moist because that suckling of the hands is important in imprinting that taste from the amniotic fluid to mom's colostrum, which has a similar taste and facilitates that first breastfeed. Again, 60 to 90 seconds after delivery, 1 to 2 minutes even, the cord can be clamped. And then the baby moved a little closer to mom for the initiation of breastfeeding. After 5 minutes, the 5-minute APGAR is assigned, and then finally, mom is assisted and supported to breastfeed by helping mom identify feeding cues, providing assistance really only if needed. So in the safety training, we'll actually give stacks or a deck of cards. Each one of the cards will have every one of these points in the sequence of events all scrambled, and each team that's at the safety training will be assigned the task of ordering those cards in the proper sequence. And so that's a fun exercise that we'll be doing during the actual safety training to reiterate the importance of the sequence of events. What about cesarean deliveries? There's a few considerations that we have after cesarean deliveries that are unique to this type of delivery. We know that both primary and repeat cesarean deliveries are still common in the United States, despite efforts to lower both. The most common indication for primary cesarean deliveries in order of frequency include labor dystocia, abnormal or indeterminate, formerly non-reassuring heart sounds, fetal malpresentation like breech presentation, multiple gestation, and suspected fetal macrosomia. The safe reduction of the rate of primary cesarean deliveries is going to have to require some different approaches to all of these different situations or indications, and that's really happening, that's evolving. For example, we're really revisiting the definition of labor dystocia. Recent data show that contemporary labor progresses at a much different rate or much slower rate than was historically taught, and additionally improved and standardized fetal heart rate monitoring and interpretation may have an effect on primary cesarean deliveries. But what about in skin-to-skin care during the cesarean deliveries? With regard to cord clamping, it's really very similar as with vaginal deliveries, unless the baby's status necessitates cord milking and immediate resuscitation. But for the most part, cord clamping can be, quote, appropriately timed or delayed, as we talked about before. It's really important to consider the thermal environment of the operating suite. Typically, surgeons like their operating suite super cold, and for cesarean deliveries, while it is an operating room setting, standards have really changed such that we recognize the importance to keep the ambient environment a little warmer for both the mother and the baby. And the temperature that we're aiming for is around 22 to 26 degrees centigrade, or about 72 to 78 degrees Fahrenheit, which sounds really warm if you're a surgeon. However, we know that that's preferred for both mother and baby to prevent hypothermia. And in that environment, the baby can be safely placed in skin-to-skin care. Skin-to-skin contact is feasible in the operating room, but should be considered as part of the standard of care for cesarean deliveries, but it's really important to bring everyone around the table to be able to be prepared. The anesthesiologist has to put the drape in the appropriate place, and everyone that's in the operating room should really be aware that this is the standard of what's being provided. It really does help the mom's perception of that birth experience, as well as all the other benefits that I shared with you earlier in terms of promoting breastfeeding and bonding with the mother, and reducing the need for formula, and also decreasing the need for analgesic and anxiolytics for that mother following a cesarean section. Very often we'll see after delivery, mom requires the anesthesiologist to give some medication to help the mother with pain and the shakes, and having that baby skin-to-skin care will actually reduce the need for that medication, which is a really beautiful side effect of having the baby there. In terms of the care of the baby while in the operating room, it's really not that different than after a vaginal delivery, with a few exceptions. So the baby's respirations might take a little longer to sound clear because of gurgling and extra fluids, which tend to be kind of squeezed out through vaginal delivery. But the effort to breathe should really be the same. So it's about being patient, maybe providing a little extra chest percussion, but babies really shouldn't be suctioned unless the baby needs help in ventilatory status. So just like with the vaginal deliveries, we have an entire sequence of events that we present for the sequence in cesarean delivery with some more cue cards and more examples and more fun in teamwork that I'm not going to go through today. So we're going to go through a couple of case examples, as I mentioned earlier. We have to make some decisions about babies that perhaps may be born through meconium. This is baby Alex, born at 40 weeks by cesarean, as you can see here. No other complications to a healthy G1P1 mother. So let's just think about, I'm just going to go back actually for a sec. Sorry. So when we think about the meconium delivery, you can look at a decision tree, which you might see posted, for example, in the operating room. And here you have a term baby who has meconium, so we're going down this pathway. you have to assess 3 things in order to decide whether that baby can go back to normal care. So does the baby have normal tone, a normal heart rate above 100, and spontaneous breathing? So if those 3 things are normal, then the baby can be dried, placed in skin-to-skin care, and continually reassessed. And I'm going to illustrate that, if I can, a little bit in what we've created here as a decision tree algorithm. Okay, so we have a baby who's term gestation breathing and has good tone, but had meconium. So we're going to say no because the baby had meconium. And in that first 15 seconds, we really have to make that determination. So the next step is to say, what's the heart rate? Is the baby gasping? Or is the baby apneic? And if any of those are true, then we would want to have that baby resuscitated with positive pressure ventilation, and we'll do pulse ox monitoring, and then we'll reassess the heart rate. And again, if the heart rate doesn't look good, then you go through that whole pathway of resuscitation. If the heart rate does look good, then again, you clear the airway and again, consider other more intensive monitoring for that baby, and that baby would not be skin to skin. So if the heart rate is not below 100 and doesn't require any further resuscitation, then that baby can go back to routine care, and that's what that looks like in the decision tree. So routine care is essentially skin to skin, providing warmth, clearing the airway if necessary, continuing to dry, and providing ongoing evaluation. So that's a little demo of how the decision tree goes for case examples. We also have a couple of other case examples just so that the learner can think about other situations after vaginal or cesarean deliveries that would require just a little different thought process. So this is a case, for example, of baby Tamika, who's born 37 weeks gestation to a mother with gestational diabetes and PIH, and the mother was actually placed on magnesium sulfate during her labor. She's awake and alert, and the neonatologist is in the room, and the baby has good tone, cries immediately, has a great heart rate. So what other factors? And so this is more of an interactive component to the safety training, where the audience will get to discuss the concerns for the mom and the concerns for the baby, such as the concerns for the baby are that that baby's at risk for hypoglycemia. So when you, going through that algorithm of when you test for the first glucose level, in addition, Tamika's a late preterm and again, on the older side of prematurity, but these babies definitely have a higher risk of compromise and sometimes have difficulty suckling, and so greater need for monitoring. And then the concerns for mom, obviously, that she's on mag sulfate with pregnancy-induced hypertension, and that might render her drowsy, so it's important to continuously monitor that mother to make sure that she's alert, awake, and able to respond to her baby. So that's just one example of another case that the teams can go through. And finally, at the end of this whole segment on skin-to-skin care will be a list of resources with the actual documents that the teams can bring up and print out and share with the other members within their staff. So now I'm just going to transition over to rooming in. And again, we always begin with why it matters, why we want rooming in to occur. We want rooming in to occur because that's really the best way for that mother to respond to her baby's cues for feeding, and it's really the best environment for care. It means that the mom and baby are staying together 24/7, understanding that baby-friendly criteria permits 23 out of 24 hours, but really that 1 hour is for the exceptions, not for standard care. We know that rooming in is consistent with contemporary models of family-centered care, and this also leads to optimal health outcomes for the mothers as well as the babies. And even in specific high-risk circumstances such as NAS, there have been great quality improvement projects looking at the improved outcomes for even babies that are opioid addicted. We also know that rooming in, despite a lot of concern that mothers wouldn't like it, that they think that this is somehow interfering with their ability to rest, there's actually improved patient satisfaction as long as that care is rendered in a way that moms and families recognize that she's still being cared for at the same level, the baby's still being cared for at the same level of care. It's just that they're in a semi-private room now. They're just in shared care environments. And it's really about facilitating mom's role as mom, but also allowing mom to sleep if needed. Rooming in helps also to provide more security, avoids abductions and switches, leads to decreased incidence of infant abandonment as well. Studies actually show that mothers who room in with their infants actually get more sleep and better quality of sleep. Also, as I mentioned, are more able to recognize their baby's feeding cues, so they're more able to and more likely to feed more times during that 24-hour period. Remember that we recommend 8 or more feeds in that 24-hour period. Really closer to 10 is best. Babies also cry less in traditional nurseries. If the newborn is by themselves, they get cold and lonely, and really newborn babies need their mothers. We learn this from other species. It's not a mystery that the newborn baby really prefers to be with their mothers. And studies have shown that babies that are with their mothers actually cry less. Rooming in also improves parental competence in traditional nursery settings. The nursery staff do everything, the infant exams, the procedures, the bath, and that means that the parents often leave the hospital without having developed competency in really caring for their baby, and for the staff to be able to recognize opportunities for education. A lot of times staff might find that the baby's placed down on the hospital bed if a mother goes to use the bathroom, and that's a perfect teaching moment to explain that if that happens in a home environment, that's a situation that could lead to a baby fall or baby suffocation. So that's a good teaching opportunity that you wouldn't recognize if there was no rooming in, or you would recognize much less frequently, I should say. So in terms of the guidelines for what rooming in should look like, it may seem obvious, but it's really important that the bassinet is within reach. It doesn't help a rooming in environment if the bassinet's parked at the foot of the bed, which is something that we do see often. It's really hard, especially if a mom is recovering from a surgical delivery, for the mom to actually get up out of bed and get her baby. So the actual baby should be able to be reached by the mother with assistance. The wheels of that bassinet should be locked next to the bed, and again, mothers should be educated about placing that baby back to sleep after a feeding is completed or when the mom wants to go to sleep. So supine position, reiterating the importance, and I will say that we still see educational pamphlets, we still see babies placed on their side to sleep, which carries twice the risk of SIDS as supine or back to sleep. We want to see that there's no other objects in the bassinet, meaning the bulbs, for suctioning or anything else. The caps, mittens, toys, everything else should be out of the bassinet. Nothing should be in there except for the baby. We recommend sleep garments as really preferred. We know that swaddling doesn't prevent against SIDS, and it actually may, in some cases, contribute. So we're actually leaning against swaddling as the preferred garment for sleep for babies. Sleep sacks or sleep garments are much preferred in terms of prevention of SIDS. Support persons can be really useful. I would say you don't want to rely on them, but certainly they should be involved in the care of the baby. Certainly if the mom is feeding and has a tendency to fall off to sleep, the support person should be educated about the importance to place that baby in the bassinet if the mom's sleeping or in the shower or off out of the room for whatever reason. And so the other care provider can provide skin-to-skin care, but then also, if need be, the caregiver can place that baby in the bassinet for sleep. Staff rounding is really important to prevent untoward events. So especially in the first 4 hours after delivery, moms are going to be even more susceptible to falling asleep with their baby, especially if it's in the middle of the night or early hours of the morning. Certainly mothers who are sedated, taking medications that lead to somnolence, or mothers that are unable to ambulate or have IV catheters or Foley catheters. All these moms should have at least hourly rounding and maybe even up to 30 minutes rounding if moms are compromised because of somnolence. So the staffing recommendations by A1 are 3-to-1 for couplet care and divided care at 6-to-1, and it's really about restructuring the available providers in the hospital in order to provide commensurate care for what you're delivering. Routine procedures can be done while in skin-to-skin contact. So if, for example, it's time for the baby to have the newborn screen, which involves a heel stick or any other procedures, it's much better to do that skin-to-skin with the mother because that, again, causes decreased pain. And what about the bath? So the bath should definitely not be done in the delivery room. We recommend a delay in the bath. Actually, baths don't even need to occur at all in the postpartum period. But if you are going to have the baby get a bath, we recommend a delay at least 8 to 12 hours after birth to try to prevent any problems such as hypothermia. Bathing the baby in the mom's room provides mom with an important opportunity for her to observe and participate in the bath. That helps build mom's confidence. This photo shows a Mississippi hospital patient restroom with a counter that's ideal for conducting the infant bath. Know that baths are best done in small tubs, which are ideal for immersion. We don't recommend sponge baths because that actually does lead to hypothermia. And those little small tubs can be placed in the sink or next to the sink, as in this case on the countertop, and the water should be checked to make sure it's tepid before placing the baby in the tub. So we're just going to show an image, and this is another interactive component of the training, and we're going to ask the audience what's wrong with this picture. And as the audience provides responses, hopefully we'll be able to highlight different parts of this picture to illustrate first and foremost that the newborns are away from their mothers, denied an opportunity for important skin-to-skin time, and also denied all the advantages of rooming in. In addition, the newborns are on their sides, as I mentioned, not supine, which is not recommended by the AAP. The head of the bed in this case is not flat, and so we're often seeing the heads of the bassinets in hospitals being elevated because of reflux, and we know that, in fact, that is not evidence-based, and we don't recommend that the head of the bed is elevated. We also don't recommend that objects are in the bassinet. There's some objects in some of these babies' bassinets. We also see the babies are swaddled, and again, the mothers aren't there, not able to participate in the care. So there's lots of different examples here about what's wrong with the picture. This is a published case example of the Sentinel event. This is a 41-year-old mom who received Duromorph after a very long labor and ultimately a cesarean delivery, and the result was that in the middle of the night, a nurse found this mom sleeping, and the baby was lifeless under her breast. And really the good part of the Sentinel event being published is that there was a root cause analysis. And the root cause analysis revealed the fact that they needed to better orient the nurses to couplet care, meaning care for the mom, care for the baby, knowing how often to provide rounding, and that there were special needs of the cesarean moms, and that the mother-baby nurses needed to participate in developing a decision tree diagram. And so when you think about making your own decision tree diagram, these are some elements to consider. You want to document the level of fatigue or exhaustion of the mother. You want to assess the level of sedation because of medications. You want to know the level of disability, for example, a cesarean delivery that might restrict mobility. And you want to have a strategy for at-risk couplets to provide bedside observation of breastfeeding, particularly in the first 4 hours after delivery, but really other times during the 24 hours is important as well. And you might include in your decision tree also the opportunity to have rest time or snuggle time or sleep time for both mom and baby. In terms of preventing falls, which is another unsafe situation that can arise in rooming in. Again, we know that postpartum women don't know it, but they are, by nature of just being postpartum, at risk for falling, and that's for both vaginal and cesarean births. And so there are fall risk assessment tools that have been developed. Most of the tools that are out there are actually for a population that is not reflective of the OB population, but there is one tool developed by Lockwood that was actually developed for postpartum women that can be used that will help assess the fall risk for any particular patient. I think it's just important to know that all mothers that are postpartum are, in fact, at fall risk just by being postpartum. So the AAP has some recommendations for how to prevent falls. One is by instituting a patient safety contract. The other is monitoring mothers according to that risk assessment, by that fall risk assessment, using the tools, implementing egress testing, which just means using a tool to assess the mom's ability to sit up or to stand up and be stable on their 2 feet and to ambulate. This was originally developed for obese patients following surgery, but can be applied to postpartum women as well. Reviewing the equipment that you have, reviewing the equipment with the mother and the family, when and how to use the side rails, for example, and how the bassinets are secured. In my opinion, I think the side rails are more of a hazard than a help. A lot of people think the side rails will prevent the babies from falling out of bed, and that's just not the case. So really publicizing and educating about all the equipment that's in the hospital. That's so often forgotten for whatever reason. People really don't know how to work the hospital beds or are taught how to use it in a state where they're not ready to really learn. Again, promoting the prevention of falls is just one way to also decrease fall risk. So a couple of interventions to consider are just, again, publicizing using posters such as this one and really assisting the moms in rooming in situations as they transition to a sitting position, assisting them with personal hygiene and toileting, and then transitioning and caring for the baby if moms really are not able to do that. And I'm going to close by just showing you a little bit of a quiz that is taken from a manuscript that helps to provide additional education around fall risk by the Lockwood article that will help, again, engage the learners during the safety training in taking a quiz and explaining issues related to postpartum falls. So the first question is, postpartum falls are categorized as, and the audience will participate and choose, and the right answer is anticipated physiologic falls, meaning that we expect postpartum women to actually have falls. And according to this article, the most important factor influencing the fall risk is the patient's ability to participate. So it's really a great idea to involve the mom and the family about in the decision tree and in the assessment of her own care in terms of preventing falls and also improving safety. So if moms say that she knows that she falls asleep every time she breastfeeds, which is physiologic and very common that the mom should actually ring a call bell and should be provided assistance in those situations. So I'm going to stop here and ask if anyone has any questions. Hopefully Paige was monitoring the chat, and hopefully you all have questions.
I have not received any questions in the chat just yet, so if anybody does have questions, feel free to start posting them now.
Or you can, if you're unmuted, you can feel free to just state your questions as well, or any comments.
Lori, this is Laura. Thank you so much. That was really was just a great example of the training we're going to do. I was just wondering, for people who maybe joined the call late, would you mind just describing again what we have?
What this is.
Yeah, exactly.
Yeah, so what this is. So, yeah, so for all of you who joined late, what Kathy Carruthers and I have done is we've taken what we've written, what the AAP policies have stated in terms of improving safety while skin-to-skin and rooming in, and taken what we presented in more of a sort of linear didactic format in webinars, and developed a 2-hour safety training that's interactive, that's a train the trainer. It's really meant to be for the leadership of all the hospitals, and we're going to kick off this training in October when we're in Jackson, Mississippi. And hopefully the leadership of the hospitals will come, get trained using this platform. This is a unique platform that's very visual, interactive, and really educates, as Kathy does for the 4-hour trainings, educates for through these visual cues and also some interactive exercises. So there's going to be opportunities to do all these exercises with sequencing of events following vaginal and cesarean birth, using quizzes, and really engaging the audience in this very interactive safety training on-site train-the-trainer workshop. And you were our beta test. This was the first time we rolled this out for a general audience. So. So any questions or thoughts? Well, if there's no questions, comments, thoughts, I'm happy to receive any by email. This is a program that's still evolving. We're going to add a few more links and continue to tweak and continue to add some great images as we continue to refine this training program. And I just want to thank everyone for participating. Okay, have a good afternoon, everyone.